Well, welcome everyone. This is the first in a series of 3 sessions focusing on long COVID. Today, we're going to be talking about recognizing long COVID. The format today will follow the ECHO model, and so we'll start with didactic presentations and then followed by time for questions and case studies. The objectives are on the slide here. I'll just go through them quickly. We want to be able to, at the end of this, hopefully everybody will be able to differentiate long COVID from other chronic conditions with similar presentations, identify different symptom patterns with which long COVID may be present, understand the potential stigma and other psychosocial concerns that patients with long COVID may experience, and gain awareness of resources available to people experiencing long COVID. We are fortunate to have 3 speakers with us today, each of whom have been working with Stratis Health and the Minnesota Department of Health over the last year and a half now, I guess it's been, to better understand really what is needed for clinicians to help people who are experiencing symptoms of long COVID. I'm going to go through each of the highlights of each of their bios. There's a longer bio on each of the slides. But first, we have Dr. Tanya Melnick. She's a primary care physician with the MHealth Fairview system. During the early days of the pandemic, her clinical practice changed, and she ended up including a lot of virtual urgent care and was part of the surveillance program for COVID-19 patients, and now has really shifted to post-COVID care, and she's the co-director of the Adult Post-COVID Clinic and works closely with her PM&R colleagues, in addition to continuing to being a primary care physician. And next, we have Stephanie Graich. She's an assistant professor of medicine and senior associate consultant in general internal medicine at Mayo Clinic in Rochester. She obtained additional training focusing on myalgic encephalomyelitis and chronic fatigue syndrome and fibromyalgia. So in her role at Mayo, she's played a really active role in research and the reshaping of care of patients with long COVID, as well as people with ME/CFS and related complex chronic conditions. And then finally, we'll hear from Dr. Farha Ikramudin. Farha is an associate professor at the University of Minnesota. In addition to teaching, her clinical work is focused on long COVID, neurorehabilitation and recovery, and spasticity management. Each of our presenters, as well as our members of our planning committee, have completed a conflict of interest disclosure, and there are no conflicts of interest disclosed that would impact this presentation. CME credits will be granted. The Category 1 AMA credits will be provided by Stratis Health, and the material has been improved for AAFP CME credit. So just so you know that to receive credits, each participant will need to complete the evaluation after each of these sessions. And with that, I'm going to turn it over to Dr. Melnick to kick us off with post-COVID cough and dyspnea.
All right. Well, good afternoon, everybody. It's a pleasure to be presenting. And I thank you so much for invitation and actually organizing this activity to the Department of Minnesota Department of Health. We're going to start with probably not the most common concern you're going to see, but you're definitely going to see it in many of your patients, and that's post-COVID cough and shortness of breath. Yeah, I just slipped through that, but that's okay. First of all, what is long COVID? We have seen patients use the term post-COVID, long haul COVID. It is defined differently depending on who you go to. So current CDC definition is actually new, returning, or ongoing health problems following acute infection with SARS-CoV-2 lasting longer than 4 weeks. So hold on, give me a sec. Don't go that far. I think you have control. However, there are alternative definitions where people wait for 3 symptoms after COVID, 3 months after COVID, and symptoms need to be present for at least 2 months, and that's WHO and UK definition. That definition, unfortunately, throws a wrench into clinical studies. So you need to be careful when you're reading them to see which definition they actually use. But that's one of the reasons studies are variable as far as what percent of patients really have long COVID and what percent of patients with different disease severity have long COVID. For all infections, the prevalence is estimated to be about 10%. That varies from strain to strain. So earlier strains, including Delta, post-COVID was more prevalent compared to what's circulating right now. And the immune landscape changed overall. So we're not seeing long COVID in new infections at this time. However, it's still there. Prevalence can change with disease severity. So people who were in the hospital definitely have higher rates of ongoing symptoms. Same goes to patients who were admitted to the ICU and were ventilated. They have the highest prevalence of long COVID. Diagnosis at this point is really clinical. It's making sure that there is no other competing etiology that explains the patient's symptoms, but there is no specific testing as of now. That may be changing in the future. I know people are looking at different markers of long COVID. None of the markers are ready for prime time yet. Again, it would be nice to have a test for chronic fatigue and many other symptoms and attribute them to COVID with readiness, but we're just not there. So we have to do it the old-fashioned way and really talk to the patient and get a very extensive history. Let's try to go for next slide. Long COVID or post-COVID conditions is really a multi-system disease. Just about everything in the body can be involved. And that goes without saying. I'm sure many of you have seen patients with it who have multiple complaints. And even after making sure that they really don't have anything else going on, and there was just the COVID as a trigger, it's still many symptoms and still many systems that are involved. And we are getting a little bit closer to defining the drivers for long COVID. And it looks like it's going to be one of those conditions where multiple things are at play at the same time, pretty much like cardiovascular disease. There is evidence of immune system dysregulation that was triggered by original virus, and that can shift inflammation in many different tissues. There are changes in gut microbiota. There is potentially an autoimmune mechanism involved, and it's not something that's readily picked up with conventional testing where you can just do the ANA and have a result that is concerning, and therefore you have a diagnosis. It may be antibodies directed toward sort of less conventional antigens where we don't really test them on a regular basis. So this is still in research setting at this point, but nonetheless, we definitely see increase in autoimmune conditions after COVID, and that also could be driving some of the symptoms in many patients. Potentially microclotting. We are yet to see therapeutics being effective for this etiology. I'm waiting for clinical studies, but it may be just one of the mechanisms as opposed to the mechanism. There are also changes in virome where we see activation of herpes viruses, including EBV and VZV. And that could be either a sign of immune dysregulation or further drive immune dysregulation. Same goes for persistence of SARS-CoV-2 virus that we actually see in both patients with post-COVID conditions and patients who have had fully recovered from it. Why immune response is different in those settings, we don't know, but this is something that is being actively investigated. And finally, all the damage, unfortunately, does not go unnoticed by the autonomic nervous system. So dysautonomia is something that is seen quite often in many post-COVID patients and could be just yet another mechanism how COVID can affect a human body and drive their long-term response and long-term side effects. So I'm going to start with one of the patients I've seen. So demographics has changed. So full disclosure, this is not all the personal patient information. But I saw this gentleman fairly recently who was referred to clinic for non-resolving cough. He had 2 episodes of COVID, and one was more recently in February of 23. He was fully vaccinated with recent booster in September of 23, had mild illness with dry cough, not treated with antiviral medications. His cough actually worsened after a month after acute illness. And without further ado, one of his subspecialty providers sent him to long COVID clinic. So cough and dyspnea are fairly common. Cough actually is less common than dyspnea. It does have some correlation with severity of disease, but not as much as dyspnea. For shortness of breath, patients who were admitted to the ICU have the highest prevalence of dyspnea, and patients who had mild disease have lower prevalence of dyspnea. Again, studies are very heterogeneous, so saying for sure what is the prevalence in different populations is next to impossible. Overall, there's definitely a trend, but trying to figure out how many of each group actually have dyspnea or cough is very difficult. Numbers are pretty much all over the place. For the causes of cough, it's a plethora of all different conditions that you have to keep in mind. And that's why getting history is very important. Some of the chronic conditions that can result in cough can definitely get worse with COVID, where symptoms will be driven by both pre-existing condition and recent COVID infection. And there are asthma, chronic rhinitis, gastroesophageal reflux disease, and interstitial lung disease. That's one of the kind of rare things. COVID can also unmask those conditions. So if they were well controlled and patient really didn't need to use any medications for asthma control short of inhaler, now all of a sudden they actually need to use the controller medication. For COVID-related conditions, all sorts of interesting things, including cough hypersensitivity syndrome, where after long coughing, cough pretty much drives itself. So it's a reset reflex. This condition is also known as irritable or hypersensitive larynx. And this is something we have seen after other respiratory infections, so it's really not a huge surprise. There are evidence of vagus nerve neuropathy that can be driving not just cough, but some of the other symptoms related to long COVID. There's definitely airway disease, anything from large airway to smaller airway, and it may present very similar to asthma. And finally, although it doesn't induce cough as often as it induces dyspnea, there's definitely COVID-induced parenchymal disease, and the severity here really is dependent on the severity of initial infection. And there are also causes not even related to COVID that you have to keep in mind. Anything that happens since patient had COVID technically is post-COVID. Not everything is necessarily linked to COVID. So making sure that patient is really not dealing with anything else on top of their previous COVID is absolutely critical for the differential diagnosis. This is just a brief evaluation, and really the approach to cough is not different from any other types of cough that you're going to see in your clinical practice. And that's the approach we typically take. So it's usually an anatomic-based approach. You start pretty much from the sinuses and go all the way to the stomach. You get detailed history of cough or related conditions prior, during, and since acute COVID infection, and you focus on clinical exam. So that actually gives you most of the information. And after that, additional evaluation is really driven by other symptoms or conditions you suspect. For non-resolving cough of unclear etiology, where people have been coughing for 3 months or even longer, sometimes you do need to refer a patient to subspecialists, including ENT or a pulmonologist. And finally, do not forget that medications can induce cough, particularly ACE inhibitors. And for whatever reason, I've seen probably more cough related to ACE inhibitors since I've started working in post-COVID clinic than I've seen before in my general medicine practice. So, getting more detailed history from that patient, it turned out that COVID-19 really did a number on his gastroesophageal reflux. He had occasional dry cough, mostly was taking over-the-counter antacids for control of heartburn. But since COVID, and that definitely can happen, he required daily and sometimes multiple dosing of over-the-counter antacids. He developed hoarseness and actually had audible wheezing. That was mostly upper airway. So the recommendations were lifestyle changes aimed at control of gastroesophageal reflux disease, starting famotidine, so acid suppressive therapy, considering changes antihypertensive therapy because he was actually on lisinopril. And because of that wheezing and hoarseness that had been ongoing for several months, he got a referral to ENT to make sure that his vocal cords are not the problem. So with that, we are moving to dyspnea. Dyspnea, again, is more common after COVID-19 infection. And this is one of the gentlemen that I've seen also more recently. He was fully vaccinated, but had a mild disease with mostly upper respiratory symptoms without shortness of breath. He had some asthma exacerbation and after COVID and was treated with short prednisone burst. Pre-COVID, he had mild intermittent asthma, some gastroesophageal reflux disease, was treated with losartan HCTZ for hypertension. At this point, he was very short of breath with even minimal exertion, which was very atypical for a fairly otherwise healthy guy who didn't really need a whole lot. And he noticed that his dyspnea was really not improving even with the change to a steroid inhaler. So something else probably was at play. And the causes of dyspnea are really tricky to evaluate in post-COVID patients because, again, it could be happening at many different points, and sometimes there is interplay of factors, and there are many things that are kind of rolled into one. So there are maybe more than one etiology of dyspnea in any given patient. But again, from upper airways, vocal cord dysfunction or paralysis could be an issue. Laryngeal obstruction or even tracheal stenosis could be a possibility, particularly if patients who were previously intubated. Parenchymal disease is actually more common than we think, even for mild cases. That was the case for earlier strains. The later strains don't seem to go into the lungs and affect the lung tissue to the same degree. But upper airway disease, particularly in people who have asthma, can be very pronounced and lingering. And thromboembolic events, of course, are also undifferential. We haven't seen as many thromboembolic events with newer strains, again, particularly in high-risk patients, because most of them get treated with Paxlovid. And this is where Paxlovid is most effective. It really drives the incidence of thromboembolic disease related to COVID-19 down. Cardiac and systemic symptoms, as well as chest and abdomen, are also something to think about, particularly for dysfunctional breathing, which we actually see quite common. So patients who were short of breath or tired tend to be more commonly affected. Also, people who have POTS or autonomic dysfunction tend to be more affected, but they start to breathe very differently. So diaphragm is not engaged in breathing. It gets to be more of the upper chest, and it often gets out of sync with what they really need to be doing. As a result, they are getting more short of breath. They may be getting palpitations, and they may be getting tachycardia because of ineffective breathing. So it's really interesting to sometimes send the patient to all the right subspecialists for them to come back and say, hey, they told me that I don't talk right and I don't know how to breathe correctly. But sometimes this is what we see, and then addressing both problems gets to be somewhat challenging. Where am I going? Oh, let's go back one more slide. Thank you. So this is where, again, clinical history absolutely drives your show. And you're getting information about both, well, not both, but acute COVID, pre-COVID condition in terms of their illness and management, as well as current symptoms in terms of both severity and duration. You need to include upper airways in assessment of the dyspnea, particularly after COVID. And for laboratory testing, remember that there are other causes, systemic causes of dyspnea that need to be excluded. For people who did not have previous chest imaging, we usually get just a plain chest X-ray before going to more advanced imaging. For people who had previous CT with findings, getting a CT to make sure those findings have resolved would be a good idea. And finally, just about everybody needs a spirometry and a 6-minute walk just to see what's going on and whether or not they desaturate with physical activity. Oh, go back. Yay. There we go. So our 50-year-old, well, my 50-year-old patient had normal chest X-ray because he didn't have previous CT and his illness was mild. We decided that CT is really not warranted for this. But when his laboratory data came back, it turned out that he had hemoglobin of 8.5 with markers of iron deficiency anemia. So he went back to his primary care provider and actually went back to colonoscopy and upper endoscopy for evaluation of anemia of iron loss. So this is just one of those cases where he had disease going on since COVID, but not necessarily related to COVID. All right, next slide. So for patients who are coming not just with post-COVID dyspnea or post-COVID cough, creating a symptom inventory and targeting each symptom almost separately tends to be the preferred approach. Because many symptoms can have so many different drivers, it's easier to have almost a table of what's happening to the patient and what things need to be done for evaluation. Clinical history, including pre-COVID conditions and pre-COVID state of functioning, is very important. Plan needs to be developed in collaboration with patients. Sometimes additional evaluation may be cost prohibitive for the patient, so making a plan that is targeted and has a different levels of priorities. If this is negative, then we are going to this test is also very important, and trusting your patient that they are reporting symptoms that they're feeling, not dismissing them, and making sure that we are addressing barriers to testing or treatment is also very important. And I am done.
All right. Thank you, Dr. Melnick, for that wonderful introduction and getting to go into cough and dyspnea. What I'm going to do now, I'm going to move back out and let's see. Perfect. And so what I'm going to do, I'm going to move back a little and talk about a more general approach to the different things that we see with long COVID. And with long COVID, right, it's complicated because we don't always use the same definitions. There's reports out there that say this is 200 symptoms of all one thing, and can get very confusing very quickly. The way that I like to break down people who are coming to me who are essentially worsening after COVID, I try to see, can I identify them in one of or two, or sometimes they fit into both buckets. So there's one bucket is what I call the familiar conditions, the things that we're taught about in medical school that my specialty colleagues know what it is and what to do with it. Things like rheumatoid arthritis, dementia, myocarditis, things like that. COVID triggering things that we know about more or less. Compared to the other bucket, which is then what have often been considered the less familiar conditions. These are the conditions of dysautonomia, of autonomic dysfunction, where we're including again, what have historically been considered the medically unexplained. My hope is that in the future we'll no longer have to say medically unexplained, because as you're already seeing, there's actually quite a bit of knowledge of what may be happening in these conditions. But these include myalgic encephalomyelitis / chronic fatigue syndrome, fibromyalgia, postural orthostatic tachycardia syndrome. You may hear about mast cell activation, among some others I won't be going into today. I'll be focusing mostly on those first three. And reason being that those are kind of the most common phenotypes that you're going to see of this less familiar realm. I also tend to call this syndromic long COVID, sometimes to differentiate a little bit better, because this is the group that most are going to have fatigue, brain fog, unrefreshing sleep, part of the syndrome that we see with ME/CFS, with fibromyalgia, with POTS again. So sometimes I'll say syndromic long COVID to differentiate a little bit more. In our clinic, we have essentially broken them down into subgroups or phenotypes that generally represent these categories. So our fatigue phenotype has generally represented similar signs of or meeting criteria for ME/CFS. Myalgia, arthralgia phenotype fitting more the fibromyalgia criteria, or close to it, having features of it. And similarly, orthostasis phenotype being more like POTS or features of it. And keep in mind that patients may often have multiple phenotypes, especially people who end up meeting or coming close to ME/CFS criteria will often have a number of these overlapping. And so to just kind of go into these conditions that you may be seeing a bit more of real briefly, ME/CFS. So there's been reports that approximately 50% of people with long COVID may meet or come close to meeting criteria for ME/CFS. Again, this is a neurologic multi-system condition that is unfortunately incredibly debilitating for a lot of people. This is the classic story of young marathon runners who, after an infection, historically EBV mono has been kind of the big bad one for it. And now COVID has taken that role, that for months, years after, they suddenly can't get up to go brush their teeth without feeling like they're paying for it. And so that idea of paying for it, the classic, even hallmark symptom in ME/CFS is post-exertional malaise, and you may be getting this or the flavor of it in a lot of long COVID patients. Post-exertional malaise is that idea that the ME/CFS body or long COVID body, because it is an energy-limiting condition, in part having to do not only with neurologic dysfunction, but also mitochondrial impairment, amongst other things that are dysregulated. Essentially, the body, if you try to push it past its threshold, that patient will say they will essentially get payback. Oftentimes, really worse the next day, can lead for days, weeks after, of multi-symptom, multi-system involvement, as characterized in this diagram that we have here. That is then accompanied also by, as far as the criteria goes, significant fatigue and reduction in function, often at least 50% of reduction of function loss from baseline for at least 6 months, and unrefreshing sleep. And then patients have to have at least one of the two, brain fog or orthostatic intolerance. And I'll have a little bit more on orthostatic intolerance in the next slide. The other one, then, fibromyalgia, is one that I think a lot of primary care providers are relatively familiar with, or at least have heard of comparatively, at least even prior to COVID. Fibromyalgia is well known for being a widespread pain syndrome. I don't have the specific ACR criteria here, but generally have to have pain in at least 4 out of 5. So the different quadrants and midline parts of the body, along with, again, fatigue, brain fog, unrefreshing sleep, along with many other symptoms, can be quite common. People with fibromyalgia also have a tendency for tenderness to touch and other sensory sensitivities. And then postural orthostatic tachycardia syndrome, or POTS, which is one that I think a lot more people have become familiar with or starting to recognize more after COVID, because there are a lot of people that have POTS or symptoms thereof, estimates of at least 70% after COVID, especially in the early variants. And so POTS, postural orthostatic tachycardia syndrome, the diagnostic criteria for that are symptoms of orthostatic intolerance, along with an increase in heart rate of at least 30 beats per minute, usually within 10 minutes of standing. I'll often ask people, how long do you feel you can stay standing before you feel unwell? And if they're saying within a couple minutes, especially, I generally can say, okay, you're likely that you have full POTS with that. And that's because the blood volume circulation is really poor. It's not getting to the head as well as it needs to in POTS, and really in a lot of the overlapping conditions. We see a lot of the orthostatic intolerance in ME/CFS as well. And so what orthostatic intolerance is the symptoms, which are marked here also on the side. So symptoms can include, most commonly we think of lightheadedness and dizziness, but we also see worsening fatigue, shaking, sweating, palpitations, worse headaches, things like that with being upright. And so this is unfortunately getting very common after COVID. So a case that I wanted to present here. So first let's start 46-year-old female who had mild COVID for 1 week. Has a family history of autoimmune conditions. And 2 weeks after acute COVID resolved, was feeling great for a couple of weeks, went out, decided to do a 5K, have fun with friends. It was a great time, but then unfortunately developed debilitating fatigue, no longer refreshed with sleep, had significant brain fog, lightheadedness, dizziness with position change, along with a lot of other symptoms. It was a very common presentation for my group. And so I want you to think for a second here of what important symptoms should you ask about, or kind of what would you like to try and get out of your next question with her. And the one that I would recommend is looking for that post-exertional malaise. And so again, bringing up the diagram with post-exertional malaise, what that often looks like. So one question that you can ask to elicit this is, how does activity affect you? And so we ask her and she says, it's terrible. I used to run daily without any issues, but now when I do something as simple as grocery shopping, I feel like I pay for it for days afterwards. And so with the different symptoms that she had, so she's showing signs of this ME/CFS or this fatigue phenotype. We also saw symptoms of orthostatic intolerance. So some secondary orthostasis, potentially phenotypes in there. We didn't really go into the full POTS evaluation with this one, but just getting a general idea. Because for us, the better that we can identify even the phenotypes gives us a better idea overall of potential management pathways that we can eventually take. Comparing that to my next patient. Let's start again with the 46-year-old female who had mild COVID for 1 week, has a family history of autoimmune conditions. And then 6 months later, noticed increasing joint pain, some muscle discomfort, but really it's the joint pain mostly, has some fatigue, has some brain fog. So kind of wondering, is this that myalgia, arthralgia, maybe fibromyalgia, long COVID? Get a little bit more history from her. She says pain is especially noticeable in the hand joints, but also present in the shoulders and knees bilaterally. Endorses redness and swelling at the hands. And noticed improvement on steroids when she got some from urgent care for other asthma exacerbation, we'll say. And we asked that same question. How does activity affect you? She says, it's okay. It's kind of hard to do with the pain, and I might feel a little tired after, but overall, I don't mind it. May even help some. And so the workup for that case had a negative X-ray and a rheumatoid factor, but ended up having a positive anti-CCP, as well as then a joint scan that we did that demonstrated increased intake around multiple symmetrical joints consistent with rheumatoid arthritis. And so it's really, I like to emphasize, with COVID, again, we're not just dealing with that syndromic long COVID all the time, right? As Dr. Melnick was also pointing out, that in cases, yes, we can have ME/CFS, POTS, fibromyalgia, and I do have cases where I'll have kind of both buckets playing a role. But what I have listed here are other conditions I found with patients who have come to me where they had symptoms after COVID, and further workup showed that they had vasculitis, had hypopituitarism, Unfortunately, for one, a brain tumor, actually, we were able to get that resected. But it's important to not let the other conditions that we've known about for a long time fade away just because someone had something worsen after COVID. There's a lot of different workup that can be done based on the symptoms that we have. Some examples are just listed here. Different flags that I think about. One, so the red hot swollen joints, think about those other rheumatologic conditions. If they're having actual falls and swerving, my patient who had the brain tumor was driving to the left side rather than just feeling imbalanced. That could be a sign of something else going on. Having progressive loss of memory or cognitive function, people with brain fog, they'll have some troubles with holding attention or word finding, but overall, it doesn't usually progress and get worse and worse and worse to the point of dementia-like behavior. So keeping that in mind. A lot of times, a lot of these conditions come with fatigue. If a patient doesn't have brain fog, orthostatic intolerance, or unrefreshing sleep, it's just fatigue. And then some other symptoms, I tend to be a little more wary that maybe something else has been triggered from that familiar bucket instead of dealing with one of my true syndromes that all kind of require those symptoms anyways. Significant oxygen desaturations should not be happening with the syndromic long COVID on its own. If they're feeling 100% better on steroids, uric acid lowering therapies is another one I've had, et cetera. Think about other things. And then anecdotally, I tend to find that people who have new conditions, like triggered from the familiar bucket, tend to start a little bit later, potentially in like that 4 to 6 month range, or maybe more common in the older patients as well. Just because the immune response to COVID is different, I see a little bit more like triggered of the familiar conditions. This is not to say that if people don't meet these criteria, that they can't have, or that they meet these kind of things that I noticed that they can't have syndromic long COVID. It's just something that I've noticed, and just another reminder to like look for things that keep those flags up for you.
Okay, thank you, everybody. Is everybody able to hear me okay? Okay, perfect. So thank you, everybody, for especially Stephanie and Tanya for the excellent presentation. This is a great segue to what I will be talking about. And before I go there, I'd like to thank the Minnesota Department of Health, Stratis Health, through the ECHO program to talk about such an important topic today. Next slide, please. So these are some of our discussion points today that we can move to the next slide, please. Okay. So, I started seeing long COVID patients very early on in the pandemic. Probably my first one was in May of 2020, and it was very clear that this was going to be a long haul. And interestingly, that's what the disease is called. And even my experience as a provider, a clinical provider, has gone through many stages. So the first couple of months when I was seeing patients, it was a lot about validation. The lockdown was still on, and patients were not sure about what they were dealing with. They were not talking to other people. So it was like, am I going crazy here, having these symptoms? Is anyone else there? So a large part of my clinical time with the patients was about validating their symptoms, that this is true and that other patients are feeling this as well. One of the things that became very evident to me early on is that the need to hear our patients, to really listen to what they are saying, because as both Stephanie and Talia alluded to, the symptoms are very variable. The symptoms are different. I usually, my anecdote is that I take the general symptoms such as fatigue and brain fog, which are the most common, and then I have the other symptoms such as pain, respiratory or autonomic dysfunction, and then there is that whole bucket of of disorders that can be unmasked by the COVID, which Stephanie was talking about. So listening to the patient became very important, understanding the perspective. For instance, there would be one patient who would say that I'm really trying to push myself and I'm having such severe PEM. And you would talk to them and you find out that they were barely able to get up out of the bed and dress themselves. And then there would be another gentleman who would say the same words, but when you went into more detail with him, you would realize that this patient actually was doing 3 jobs that he was doing before, and he was probably doing more than an average person. And this would be the person I would say, I need you to hold back a little bit. Whereas the other person who was not able to get out of the sofa, to prevent deconditioning and sarcopenia, as well as aging, because as we know, this disease is not just lasting 2 or 3 months, it's lasting for years now. To prevent that age-related deconditioning, it's so important for them also to just move a little bit, push a little bit, something that we call pacing. So listening to the patients became very, very important in this journey for me. I realized the importance of it more than any other time. Next slide, please. So talking about the perspective of the patient, some of the things that I want to, have you pay attention to is if you look at this systematic review and a meta-analysis of 41 studies, it shows that that majority of the patients were of female gender, older age, higher BMI, patients who smoke, pre-existing comorbidities, and previous hospitalization and ICU admission were the risk factors. But if you look at most of the long COVID patients are female, older age group, and higher BMI. So you can now start seeing the social impact of what population are we looking at? Women, older age and higher BMI. I mean, these are itself populations that are not paid attention to even in our clinical care. So now we really have to pay attention to what we are seeing over here. Next slide, please. And again, I'd like you to pay attention to this particular slide. And this is, if you look at the age group and the percent in the age groups, you'll see that it's in the younger population compared to the older population. And again, more common in females. Please. It's from through the survey that was done. I'm so sorry. Yes, household pulse survey that was done, and it's ongoing right now. So again, it also points out to people of the females. And another thing that it points out to is this is also common in people who are younger, the working group, the folks who provide the labor in our country. Next slide, please. So that's what makes this disease an orphan illness, something that not many providers want to manage. Common in females, there are symptoms, but there are no clear signs. Most common symptoms are fatigue and brain fog, and these are very subjective. They are not objective. We try our best in our clinic to incorporate scales such as a PROMIS scale that I absolutely is one of my favorite, PHQ-9 scale, GAD-7. And so we monitor patients through some sense of objectivity there, but these symptoms are mostly subjective. And the diagnosis is mostly clinical. There are no specific diagnostic tests that make it even more difficult. So you can imagine when you put all these, where are we heading towards? Now, in my clinic that I have been to, I do discharge patients who do get better. But never do I see a patient whose PHQ-9 score is very high or whose generalized anxiety score is very high. They never end up getting discharged from my clinic with those high scores, because I feel that mental health conditions or concerns really impact the way long COVID presents itself. It does impact it. Not to say that long COVID is caused by depression and anxiety, but if you were having symptoms such as these and you were a marathon runner and now you're barely able to do your daily work, of course you're going to have an adjustment disorder. You're going to feel depressed. You're going to be anxiety. You are going to have PTSD with the ongoing new variants that are coming on. So all these lead to a disease that is an orphan disease, difficult to want to work with. Next slide, please. So some of the psychosocial concerns are inability to sleep, and many of these patients are in a state of jet lag. We know from clinical studies that a viral RNA was found in the centers in the medulla, which involve the circadian rhythm. So it actually is almost like a jet lag, and these patients are not able to sleep. And all these lead to depression, anxiety disorder, and anxiety and adjustment disorder, as well as PTSD. So it's very important to say that these symptoms result in these symptoms of depression and anxiety and PTSD, and not the other way around, leading to poor quality of life, lack of treatment options, inability to participate in social roles, inability to work, and absenteeism and presenteeism. Absenteeism is when a patient is unable to, or a worker is unable to come to work. And it becomes more of a habit because of whatever reason. And long COVID patients do have absenteeism in their presentation. Presenteeism is even more interesting, where these are those patients who do come to work, but if you ask them, they will be able to tell you that I am not working at my 100% efficiency that I was prior to getting COVID. So this presenteeism is also very important, and it really impacts the patient's self-worth. Next slide, please. This is a very interesting study of 2,250 patients with long COVID who were 7.6 months from the acute COVID initial attack. This is based in UK in PLOS ONE published in year 2022. The average age of the patients was 46.5 years, and 82.8% of the patients were females. And we found that 17% of the patients were unable to go back to work solely because of the long COVID illness. And 37% had a loss of income. And these were the patients who were returning to work, but at a part-time basis or with accommodations that were difficult for their employers to put in. 65% of the patients were unable to perform their usual activities or duties. Next slide, please. So what is disability? If you look at American Disability Act, it defines disability as a physical or a mental impairment that substantially limits a major life activity. And if you look carefully at the definition, note that there is no presence of how that impairment happened. There is no such thing that it has to be a neurological disease or that it has a particular condition. It is just a mental or physical impairment. So that's a very important thing to take away from this definition. Next slide, please. And here is another slide from the same database, which shows that if you look at patients by the level of education, the highest is in those who are college or have associate degrees. So you can imagine this is impacting not only your labor class, but also the white collar jobs. And another thing that is very clear in this database is that patients with disability were higher than those without disability. So it does impact their quality of life overall. Next slide, please. So knowing your employer is a very important factor returning to work in the long COVID patients. I've come across QRCs who come to the clinic along with their patients and become a very important tool for them and a resource for them. And and the relationship of the employee to their employers, I think, plays a very important part about who is going to return to work in what form and shape. And I find that those employers who are more compassionate about their employees tend to do a better job, and these patients have a higher rate of return to their jobs than those who do not want to have any accommodations. So having a good relationship with your employer becomes a very important part in this day and age of the post-pandemic world. Another one is knowing the Department of Human Rights. I have one patient. In fact, anecdotally, what I see is that patients with long COVID who are in healthcare tend to suffer the most when it comes to going back to work. One of the reasons could be that nurses, physicians, NPs, PAs, their jobs have a lot more processing and involve a lot more memory than other jobs that may be not so. But also the employers tend to be much less flexible in getting them back. And that has been my personal experience. So one of the patients I have recently, who's a nurse, actually works in the ICU, she asked for accommodations, and these were very simple accommodations, very reasonable. And she took back the accommodations back to the hospital's administration, and they refused to do that. So she went back to the Department of Human Rights, and had these connections between the employer and the department, and actually had a very much better outcome. So I would ask providers to actually involve the Department of Human Rights when it becomes difficult for employers to listen to your accommodations that you're recommending for your patients. Knowing the law becomes very important as well. What I do find is getting reasonable accommodations is very important. So when I do write my workability letter or documentation for how to return this patient to work, I'm constantly asking the patient as well as their QRC or the patient about the environment that they live in, if these accommodations are reasonable from their perspective, or would these be very difficult? So having reasonable accommodations is one of the civil rights, even in long COVID patients. Very, very important. Next slide, please. Knowing the law and, again, having the disability accommodations in the workplace, being reasonable, talking to your employers, getting a QRC involved, very much, very
I'm a nursing home doctor. Yeah. All about the
next slide, please. So workability documentation is not something that I do alone. I always have the patient with me so that I know how much do they think that they can do. And knowing them well I don't start the workability documentation right on the first visit. I like to see the patient a little longer before I can determine how much they are doing. Some of the things that I go for is different levels of functioning. Are you able to get up and do your activities of daily living? Are you able to go for a walk? When you're going for a walk, are you getting any symptoms of that Stephanie was talking about POTS? Are you getting any PEM, post-exertional malaise? How far are you able to walk? So getting a good idea of where they are functionally really helps you know when you can push them gently and when you do not. AAPMNR, which is American Association of Physical Medicine and Rehab, has a very good consensus statement on the management of fatigue, and they describe the rule of 10, which is pushing the patient to do a little bit more. They should be exercising on a regular basis within reason, and On the 10th day, increasing that intensity and duration by 10%. So I keep a very good eye on that to see how much the patient is able to tolerate doing that. So that helps me with the documentation as well. Working out the QRC, looking at their PROMIS scores is also a very big input for me. And developing accommodations that are realistic is very important. Next paragraph, please. A slide, please. So one thing that I do want to talk about is patient advocacy groups. There are several patient advocacy groups. Some that are in Facebook. Some of them are within US. Some of them are national. Some are based in UK. And many of these patients are huge advocates for themselves and their and long COVID patient. So you need to be aware of that as a provider. Know that you are being discussed in these advocacy groups. Patients have read a lot when they come to your clinic and they know what's going on. They may ask, and some of the patients who had asked me was if there was mRNA identified in some of these smaller clinical studies, whether be it in brain or in the GI tract with endoscopy, why can't I get Paxlovid? So very interesting questions, but understanding the patient from their perspective is very important, and listening to them, because you can see both from Tanya's talk and Stephanie's talk, it's easy to go out on $1 million workup. And yet you want to be very careful that you do not do that workup, so that you are fair to your patient. So listening to the patient becomes very important. Thank you.
Well, thank you, everyone. We have a few minutes left. I just put in the chat that if anyone has any questions, chat them in. Otherwise, you can feel free to raise your hand, and we will go through questions as our last minutes allow here. While people are either typing or thinking about questions, I just want to do a thank you to all the presenters. Lots of good information. COVID taught us a lot, and it's continuing to teach us. And I think this learning about long COVID and how it relates to so many other conditions is just really important, especially for us that are working in primary care. Looks like.
Jane, there is a question in the chat. In addition to PROMIS 10, are there any validated scales for tracking fatigue and brain fog symptoms?
I think Stephanie also would have input in this, but there are several. The therapist also records some fatigue scales. There is the FAST fatigue scale. There is a Chandler scale, as well as some MEA scales developed by, I think, Jason from Wake University has developed a fatigue scale for PEM. We also track the depression scale and the generalized anxiety scores.
Yeah, agreed. Those sometimes, especially getting more into like the ME/CFS long COVID overlap, the SF36. There's a new one, FunCaps, that is out and really good for like severity of ME/CFS and long COVID patients as well. But we also use PROMIS a lot for fatigue and function. So all good options.
Thank you. Any other last questions? I just want to remind everyone to fill out their evaluations, as that is what we'll use to complete the CME credit. Oh, thank you. There we go. There's the QR code and the link, and then those will be mailed to everyone that attended the session. And reminder that this is the first of 3 sessions, so we hope to see everyone at session 2 and session 3. One more question popped in here. Can you comment on melatonin as an adjunctive treatment for fatigue, sleep, and fog issues?
In my practice, I use melatonin quite a bit, and it's one of the first ones, given that it's a natural product. Also, given that there is actual dysfunction of the circadian disorder, I will put them on melatonin at a smaller dose on a regular basis to help them improve their melatonin cycling.
Agree. And in the third session, we'll get to go a bit more into treatment of the different symptoms or syndromes that we see in long COVID, but melatonin is popular. We'll talk about potentially some other medications at that time often. And I encourage generally that things that are helpful for sleep, those can actually make a pretty big difference in a patient trajectory, especially early on. So if they feel more rested, that allows kind of the system in general to rest more. We do see more likelihood for improvement. So if melatonin works for people, I tend to agree with continuing it.
Well, looks like we are at the top of the hour, and I really do appreciate everyone joining us. And again, hope to see everyone for session 2 and session 3.
Thank you.
Thanks, everyone. Thanks, presenters.